for us to do this. So we're going to have a conversation now about inhalers, because no one wants to talk about inhalers, right? But the issues of inhalers and the issues of inhalers and climate. And really the concept here is, are metered dose inhalers the great evil? And are they going to lead to the world dying just because of MDIs? There's been a lot of noise about that. So I'll get a bit of history of that, and we'll talk a little bit about that. My disclosures, I work for everybody, but it doesn't matter. It has nothing to do with this talk because we're talking about climate stuff. So we're going to talk about climate change and respiratory health. Now, Chris did a really good job on that. I'm going to add a couple little things in there and emphasize a couple of things he's talked about. And we're going to talk about legislations that have occurred to make these rules, and we have to deal with these rules. We're going to talk about the place of MDIs and greenhouse gas emissions as an issue. And what can we do as clinicians to make a difference overall is the big picture, and what shouldn't we do perhaps? So you know that there's a story here, and way back when in the 60s with blue inhalers coming up, we recognized the ozone inhaler Chris talked about was being affected by CFCs or chlorofluorocarbons, and it was recognized that these are actually depleting the ozone layer. If you deplete the ozone layer, then the sun can get in, but the heat can't get out, and so on. And actually, Ronald Reagan and Margaret Thatcher, there's a bit of trivia. They actually the ones to create the Montreal Protocol, but it did happen in Montreal, so we actually have a Canadian issue with that here, so that's great. And the idea here was to phase out CFCs and get rid of CFCs. CFCs in MDIs were given an exemption, and it took another 20 years before we actually got rid of the CFCs in Canada. And that meant we actually lost some medications that are no longer available. Anybody remember Tylaid? Remember? Okay, Endocrimil and a non-steroidal anti-inflammatory, that never could be made as an HFA, so that drug has disappeared. It's actually a very good drug for cough and so on, and a milder drug for asthma, but anyhow, we don't have it anymore. So there's cost anytime you make a change like that. We lost some things, but it did take 20 years for that to happen, and a lot of money. So I want you to remember that it did take a long time for that transition to occur. So that's the concept of the ozone layer leading to heating up in the atmosphere. So the concept here is, well, HFAs are also bad for the environment, also lead to greenhouse gas emissions and so on. So we need to get rid of those. It seems fairly straightforward. However, if you look at sort of the numbers in terms of the effect of it, in terms of global warming potential, the CFCs are much worse, and the HFAs are not insignificant. So we do have a reality there. We do have an issue where it's time for us to think about big picture climate. We actually want to do what we can do, and therefore, if we were to make a difference like that of getting rid of the HFAs, in theory, that would make a difference. We're going to come back to that. I want to point out that there are new ones coming, and I'll come back to this, that have a much lower greenhouse gas emission, a much lower global warming potential. So I'm going to come back to that because recognize new stuff is on the way. Now, Chris opened us up beautifully. I can't, you know, he's a world expert. You know, I went to his talks at the ERS this year about this as well. He's really a world expert, and I've worked with him on some of these issues. And climate change is important. The world is changing. We need to do something about this. There's no question about that. Because climate change is going to lead to the global warming we talked about. We've already talked about wildfires. Permafrost thaw is an issue in terms of water. Of course, if wildfires, deforestation is an issue, that's going to also then lead to change in the climate and everything that's happening. We talked about ozone. We talked about CO2 production with the greenhouse effect. So all of this is going to then lead to this warming and all the effects of warming and all the effects that should happen here. So if you sort of look at this kind of picture, and the line is the CO2 concentration, otherwise it's temperatures, you can see over the course of time, we are really getting warmer. We're getting warmer. And most of that warming has occurred, as you can see, in the last 20 to 40 years. So we've managed to be okay with our planet up until the last 40 years, and now we're falling off that cliff of the temperature going up. So it is an issue that we actually have to deal with. And the interlinking of climate change and air pollution is very real as well. So again, if we've got thicker stuff in the environment, we have temperature, we have everything trapped, the stuff can't get out in terms of particle matter that Chris talked about so nicely. So now we've got the relationship between pollution and climate change. So these things are all factors. So let's talk about all those things that climate change can do. And again, I'm going to go through this quick because we've talked about most of it already. We didn't talk about floods. Right? It seems like every time you turn on the news now, somewhere there's a car with this much water up to it, right? Constantly around the world now. Why does it happen? Because of storms? Is it precipitation changes? Is it that thaw of the polar ice caps and so on? Is it we talked about the heat stress that Chris talked about very nicely. There's an issue with disease vectors. So not only are we seeing disease, we're actually seeing differences and changes in diseases. and different diseases that are coming because of that temperature change that's occurring. Something as simple as ticks, which in Ontario was not a very big problem. Now it's marching up as further and further north, so we're getting tick-borne illnesses as an example because of things warming. Something again, you get disruption of food venues, and you get flooding out of your grain areas. You suddenly don't have food production. That's going to be occurring as well when you have that kind of stuff. All that's going to lead to health impacts, and of course, who's going to affect mostly is those people are vulnerable. Right? So you all know who vulnerable people are, and the concept here of the regular sort of pyramid. Well, first more visits, more medications, more emergency room hospitalizations, then mortality. So that's the picture here that I'm trying to paint of the effects of climate on all of us. Of course, we're going to talk more specifically about respiratory patients. World Health Organization, which has its issues, I won't say it doesn't, but recognizing that the number one global threat they recognize was air pollution and climate change. There's lots of threats in our world, but they recognize that was number one. So I think we have to recognize, hey, that's something to talk about. So we've got all these different problems, all things we've talked about. There's going to be issue of the different pathogens, exacerbation of mold and dampness like that. So again, I'll come back to other pollens in a minute, but mold-borne illnesses, is a big deal. If everything's wet, it gets moldy. Things like that happen, right? Change in the pollen I'll talk about. And then of course, the whole idea of air quality. Now, Chris didn't mention the concept of the Air Quality Health Index. Who's familiar with the Air Quality Health Index? Okay, so a number of you, who checks out the Weather Channel? Okay, so they're both together, right? Because you always see the Air Quality Health Index on the Weather Channel. So this is something that was created, I guess it goes back about 10 years now, might be inaccurate at the timing. It was an initiative with the College of Family Medicine as well as a bunch of other groups that said, hey, we're going to try to put air quality monitors all across the country. You can go airhealth.ca and you get an idea of what the air quality is in most of your locales across the country. So any one day you can get an idea of what your air quality is. So while that action plan that Chris put up is really great, we have a sort of action plan with air quality, which basically says on a bad air quality day, if you're more likely to get in trouble, don't go outside. Don't exercise outside. On a good air quality day, it's a good thing. So if you're young asthmatic, good air quality day, go running. Bad asthmatic on a bad air quality day, do your exercising inside. Little things like that, just common sense, avoiding those bad days, because bad air quality days are associated with asthma exacerbations, COPD exacerbations, coronary artery disease, and acute MIs and heart failure exacerbations. It makes sense. So we know all about that. So airhealth.ca. So you're going to hear about Arexvy, I think, tomorrow, but here's an example of the RSV seasonality changing. So it's one specific vector I thought I'd throw out there because something relevant to all of us. It used to be very reliable that it would start in mid-October and end in March, and now it's starting in September and ending in May. So it's changing the timeline of this. So again, is that climate related? Is it other reasons? Don't have the answer, of course, but we're seeing changes in the pathology of our illnesses in terms of the timing of them as well. Here's something I pulled out of Lancet Oncology. Of course, the relationship between fine particle matter and lung cancer. That shouldn't surprise any of you that this is a relationship. If you're inhaling bad stuff into your lungs, your body is going to then metabolize it and have to deal with it, and some of that's going to be mutagenic. And it's recognized as a class 1 carcinogen or group 1 carcinogen. Okay. Now, some of you might be involved in lung cancer screening, where we do a really good job. Actually, we do a terrible job yet, but we're trying to do a better job on screening smokers, to prevent, to make earlier diagnosis of lung cancer to prevent mortality. But we don't take into account things like air quality. That stuff isn't included in there. So we got to figure all that out over time. And the idea of the air allergens changing, increasing pollens can occur as well. I talked about mold as well, but here's pollens. And of course, as you know, increased pollens. If you are allergic to pollens and have reaction to that, you're going to have more trouble with your illness, with your asthma and rhinitis and so on. So this stuff is all going to be related and it's changing. So the legislation. So this F-gas regulation was done in the European Union to decrease the F-gas emissions by 2/3 by 2030 compared to 2014 levels. So it started in 2014. Then they made another legislation to say, okay, this is going to happen for inhalers by 2027. We are going to get rid of MDIs. That was the definition. That's what they decided they're going to do, because MDIs have propellants. Those propellants we've talked about already will have greenhouse gas potential. Now that's an issue because in Europe, a lot of those MDIs are exported to other countries, including here. So we have issues that then are going to have access of these medications if they're banned, and they're banned cold. This is not a gradual ending. This is a date where it has to be stopped by. So if we're stopping medications and we don't have alternatives, what are we going to do? So Europe manufactures about 70% of the inhalers. So we're going to get a global supply chain. Well, we're not familiar with supply chain problems anymore, are we? I mean, we've never heard that terminology. You all know what that means now because we've been living it, right? So almost 350 million MDIs are manufactured in Europe every year. So we may not have those MDIs available. And it's particularly going to be an issue, maybe less so for us. We have alternatives here. We'll talk about them. But in developing countries, that's all they have. Okay? The World Health Organization essential medications include beclomethasone MDI and salbutamol MDI, and actually tiotropium, interesting. Those are the three. Right? So what are they going to do if we don't have MDIs? So we're going to have a problem with this. Now, in the meantime, industries recognize these issues. They're not a brand new thought. And therefore, they're investing in next generation MDIs. And I showed you a couple of those before, and I'll show you more about that afterwards. It takes time, though, to actually create the studies and the molecules and test them to make sure that they're going to be approved. So we can't just go one to the other and switch. It doesn't work like that, right? Because you have to actually do the timing. It takes time. Remember I said it took 20 years to transition off CSEs. This is expected to be happening with HFAs in just 3 or 4 years. Is that possible? Can we actually do that? Can we fast track a drug development in our country to occur that fast? It doesn't happen very often. It happened for COVID vaccinations, interestingly, so it can happen if people have the will to do that, but that's another conversation. So we have the issue then of access issues, of premature switching or switching perhaps inappropriately, which I'll talk about. And what's all going to lead to? It's going to lead to exacerbations. And guess what causes a lot of greenhouse gas release? Hospitalizations, acute care issues, which I'll talk about. So I want to take one step back and say, okay, so we're talking about inhalers, and that's what the talk was about. That's the topic that Cheryl and I came up with. We're talking about, but let's look at the big picture here, right? These F gases in propellants in MDIs are 0.1% of the total global greenhouse gas in the world. Are we right to spend this much effort and excitement about it? And how many of you actually heard this story about MDIs and getting rid of MDIs and they're a bad thing, we should stop them? Okay, so some of you have heard about it already, some of you actually haven't, or your arms are very sore from your flu shots. So that's fine, but the concept here is that MDIs are bad because they release propellant and greenhouse gases, and therefore we have to get rid of them. That's been the story. Okay? But this is the amount they actually do it. So let's put it in perspective worldwide. Right? You can't read this, probably it's a little too small, but but this, on the left side here is a whole list of all the different things that also from indoor sources can actually cause release of these kind of chemicals, right? So there's lots of stuff there, right? A lot of it you see from fuel, tobacco, smoking, coal, various construction things, and so on. All that's there. And of course, the list of things it can do in terms of the respiratory system is, as you'd imagine, not good, right? Anything from exacerbations to mortality. So we see all that. Loss of lung function. The increased FeNO slide that Chris showed is very interesting, right? So that's going to cause inflammation based on a non-allergic type of inflammation that occurs because of wildfire smoke. So all this is going to worse. So it's not just that. This is the scary stuff. So in China, 56% of the energy comes from coal, and coal is a very dirty burning source. It does not burn cleanly at all. It leaves lots and lots of stuff in the environment. In India, 55% of the energy needs are from coal. In Germany, 36% of the energy needs are from coal because they got cut off from Russia with the war, right? So they had to come up with another alternative to get energy because they didn't have enough. And of course, our prime minister didn't think it was important to sell anything. I won't get into him. You'll be very subtle about how I feel about him in the next couple of slides, all right? And this is interesting. So this is South Africa, and they have these coal-fired power plants, and they used to have technology to get rid of the sulfur dioxide, but they decided that wasn't important, so they got rid of it. What are we doing? Okay, these are big, huge amounts of stuff that's going to mess up our climate, okay? And that is okay. it's going to take, in order to keep under 2 degrees of warming, we have to leave almost 90% of the coal in the ground. Is that happening? No. No, we're burning a dirty fuel, right? So we need to make changes there. So big picture, we have a lot of places to work on. Okay, so let's just get rid of all MDIs. Better yet, let's make it a law, because politicians love making laws. It's very impressive to say, I'm going to change the climate. I'm going to save the world. I'm going to be the one. You know how I feel about him already. You get an idea. Never mind the fact that he's, carbon tax on, carbon tax off, oil, gas, never mind. All right, but the idea, he's just going to spend lots of money, okay? And he say, I'm going to promise the world, and I'm going to get reelected. I'm going to get it on the fact of a climate action, although I have great doubts he actually knows what he's talking about. There's also all kinds of other advocates. I love this young woman. You all recognize her. She's going to save the world as a 15-year-old. All right, okay, fine. Can we, as educators, physicians, clinicians, can we actually save the world? Can we do something about solving the climate? Well, I think we can do our own little part. Choosing wisely, you've all heard of. So they have a number of different initiatives to try to improve things. And one of them is talking again about inhalers. And one of the things they're tracking is the number of MDI prescriptions. It's not wrong, it's just narrow. And that's, I think, the message you're going to get from me. You may have seen initiatives like this. So the Cascades program, which Chris is very involved with, that's some of the first stuff I worked on Chris with, is a program that comes from BC. Anybody involved with Cascades here? Okay, so I'd let you talk about it if you did. But okay, so this is a program where a lot of people sort of talked about this initiative as the thing, that inhaled propellants are greenhouse gases, that have significant effect in the healthcare sector of the carbon footprint. And you may have seen a picture like this, that 100 doses of MDI is equivalent to 290-kilometer journey, right? And that's not untrue, okay, that MDIs have an effect on propellants. They do that. They then created posters like this that they've distributed out to offices to say, hey, if you're a patient on an MDI, you need to change to a dry powder because the carbon footprint is so much larger if you use an MDI than if you use a dry powder. It's all on you, patient. You have to make this change to save the world. Now, I'm not being critical of Cascades because they've actually got some very reasonable flow sheets. So again, does the patient have a diagnosis that's confirmed that needs an inhaler? Very good question. You all know that MDIs are used like water out there in practice. Okay. Every single person that has a cough gets an MDI or gets an inhaler of some kind, right? Okay. If anything happens between here and here, they get an inhaler, right? Okay. Like I say all the time, I said, anybody thirsty? No thirsty? We just had a drink. Should you have insulin because you're thirsty? Right? But if you have a cough, you get an inhaler, right? So we need to make a diagnosis first. And you all know that. And should we actually consider an environmentally preferred inhaler? I don't know if that as a second question, but okay, it's not an unreasonable question. Choose what you can if you can. Has the patient had enough training? This is your guys' bread, as Andrew likes to say, it's your bread and butter. But this is what you do all the time, thank God, because nobody else does it. Doctors don't do it. The pharmacists don't do it. I apologize for any pharmacy CREs in the room. I know there are some, but as a rule, they don't do it. Right? So it's not happening anywhere. It's not happening by the respirologist either. Shh, it's a secret. Right? So, and then what else? I'm going to come back and talk about disposal in a little while. So this is a very reasonable thing. They call it a sustainability pathway. Makes some good sense. There's some good points here. Let's make a diagnosis. Let's use the right inhaler for the right puffer, for the right patient. And if they can use an environmentally conscious one, that's great. But again, perspective, right? So first of all, they're not all the same in terms of how much carbon footprint they accumulate. But for the most part, a can of Coke has bigger carbon footprint than an inhaler. Perspective, right? Orange juice. Anybody think orange juice was going to be a problem for the carbon footprint? Okay, this kind of stuff. All right. Yes, Karchep. Never mind a hamburger. Don't have a hamburger, right? That cows are the scourge of the world, right? Unbelievably, in our country, they are now limiting the number of cows that farmers can have, so they decrease the carbon emissions. And yes, cows create carbon gas, right? You know how that works. Do I have to get graphic about that? No, that's okay. All right. So yes, they do that. But what are we going to eat if they get rid of all the cows? Like, I'm trying to understand my way around this. Right? So what about acute medical care? Well, you go in the hospital, you're going to cause a lot of carbon footprint. So I guess we shouldn't put people in the hospital, right? That was facetious, sarcastic. Okay, all right. You all recognize that the biggest use of MDI is SABAs. It's not even close. It's like 1,000 to 1. And the big problem we all have, and you all see every day, are people that overuse their SABAs. It's an old story now. You know about it. We've been talking about it for a long time. SAB overuse is a big problem. And no matter where you are in the world, SAB overuse is anywhere from 16% to 70 some odd percent. So big problem. And SAB overuse means they're using more SABAs. And what are they not using? What they're supposed to be using, right? So again, if you look at this in total SABA prescriptions, you look at the different places around the world and how much greenhouse gas emissions are occurring because of the SABA, it's staggering. So if you have to pick an inhaler to work on, that's clearly the one we have to work on. So we'll come back to that thought. Scary, I'm sure you've seen this, the Sabina data before. It talks about if you look at the number of canisters you use, and the more canisters you use, the higher the risk of exacerbation. And I think I have mortality. No, I don't. I thought I had a mortality slide in there. The higher risk of exacerbation and mortality. If you use more than 2 canisters of SABA per year as an asthmatic, your risk of exacerbation and mortality goes up. And the more you use, the higher the risk. Okay, so what does that mean? Well, we want to minimize the use of short-acting beta agonists. We want to do that, right? Because we talk about asthma control. And the first question we all know of all the control questions is how much SABA do you use? Okay. All right. If you look at the amount of greenhouse gas emissions for a controlled versus an uncontrolled asthmatic, looking at it a little bit differently, you can look at the subtle numbers, but the boxes are really different, right? It's not the same at all. So clearly, the best thing we can do for our patient, but also for the climate, is getting our patients controlled. Well, you do this every day with the patients you're trying. There's all kinds of reasons why they're not controlled. We all know what they are. We can go through them. But again, the big picture here for the climate is let's get our patients controlled. Obviously, I stole this slide from someone else. It's really subtle, right? So, but what the point here is, he's a friend of mine, he didn't mind, but he wouldn't give it to me. I don't know what that means. But anyhow, I don't care if he minds, I stole it anyhow. So 1 day of hospitalization is equal to 6 months of an HFA utilization. It's such a strong story. You can't steal the slide that I stole from someone else. Come on. All right. So, go ahead. So the point here being, okay, is what's the cost of doing things wrong, right? The cost of one hospitalization makes all the rest of the puffer conversation nonsense. Right? All right? COPD, same kind of thing. Here, it's not so much control, it's exacerbation. So if you're exacerbating with COPD, you're going to have a much higher level of greenhouse gas emissions. Okay? So again, big problem. So what do we need to do? We need to get people controlled with their asthma, prevent exacerbations, and try to prevent COPD exacerbations, which of course we should be doing anyhow, right? So a quick message. Okay? You've got people that come back to you and they're on therapies that don't, from a hospitalization with COPD, and they're not on triple therapy. What are you going to do? Make sure they're on triple therapy, right? I mean, Pierre alluded to that when he was talking about cardiovascular mortality. You've heard all about that. But the reality is, if you delay putting someone on triple therapy, who should be on triple therapy even 1 month, the risk of hospitalization and exacerbations is very, very high in that first month, because you all know the highest risk of exacerbation is right after someone's had it. Okay? So do it right away. I don't care which one you choose, I don't care which one you use. That's not my conversation here. But certainly, as you also know, the triple therapy in one device outperforms triple therapy in 2 devices, right? So we call it single inhaled triple therapy versus multiple inhaled triple therapy, and better persistence, better outcomes, decreased exacerbations, and decreased mortality. So if you're going to give somebody triple therapy, give it to them in a single device, as long as they can use it. Another conversation. Okay, so if no pressurized ventilators, what are we going to do? We could change everyone to a soft mist inhaler. Does soft mist inhalers have propellant? They look like they do. It's a nice, beautiful spray. How does it actually work? It sends 2 sprays of the medication without propellant, and it hits and makes a plume. So there's no propellant in it, except we don't have all the drugs we need in soft mist inhaler. So that's a problem. Should we change everyone to a dry powder? Okay. Again, we don't have every drug in a dry powder. And can everybody use a dry powder? I'll come back to that. Can we get new pressurized MDIs with less greenhouse gas potential? Talked about that. I'll show you a little bit more. But the biggest issue, of course, is do a better job. I'm not being critical of anyone in this room, but of all of us all together as society, we know that we're not doing as good of a job as we could do for obstructive airway disease. Not because of us, because of everything, all the reasons. So this sort of looked at that. This is some authors from Toronto. Samir, most of you know, he's a respirologist in Toronto, and Samantha's a family doctor at the Department of Family and Community Medicine in Toronto. And they came up with this and said, hey, they looked at comparing making the right diagnosis and treating people properly versus changing people from an MDI to a dry powder. And you know what? Doing it right actually worked just as well, if not better. Wow, what a revelation. Let's treat people and have them controlled and do things properly. And Samir, and I was involved in this as well as Louis Foupelet and Andrew Curry, created an electronic asthma management system. We got trialed in a number of different family health groups and organizations. We included in that the carbon footprint and the cost and so on about this. And notice the disposals in there. Kind of come back to disposal again. But everything here says it'd be nice to actually return it to the pharmacy. I'm going to come back to that. So again, we're talking about this now, and it's an important factor, but I don't think it should be the only factor. So should we just use dry powders? Sounds like a good solution, right? Sounds like it's pretty easy, but inhalers are not interchangeable. You know, these are not easy conditions to treat. I think they're actually, I can make them fairly simple in my head, but when you actually go to patients, it's not always that simple. There's no consensus about inhaler switch delivery. Is it going to be the same? And there's actually a number of reviews on this, but one of them I talked about done by some colleagues of mine actually looked at this non-consensual switch. In other words, we're just going to switch you from an MDI to a dry powder just because. And guess what? It harms the patient-doctor relationship, and it actually leads to bad outcomes and worsens respiratory disease, and people get exacerbations. And remember that stolen slide? Exacerbations cost a lot of greenhouse gas. So this work again, Omar Osmani is actually a world-renowned inhaler technique specialist, respiratory doc in London. And he's a lead author on this, and some other colleagues I know here. But what's the message? Well, get the patients involved if you're going to switch. Get their consent before you switch. Let's make sure that we don't switch for non-clinical reasons, okay? And make sure, and I love this, mandatory formal training to patients before and after switching. Wow, let's make sure they actually know how to use their inhaler. So here's two initiatives that scared the crap out of me, okay? The first, the UK government, because this all started in the UK, made a decision. Again, politicians and medicine just don't go together, but don't get me started. Right? They made a decision that they need to change people from MDIs to dry powders. So what they did is they said, okay, doctors, we want you to do this, and we're going to pay you a bonus for every patient you switch. What did the doctors do? They switched everybody. Did they see them first? Did they talk to them first? No, they went in for their MDI medication. They came out with the dry powder. Anybody teach them how to use it? Okay. Sorry again, pharmacists in the audience. The pharmacists teach them? No. The doctors didn't even talk to them. So what happened? Chaos, exacerbations. To be fair, they finally recognized it was a problem and they rescinded that and they stopped paying for it. Good. How about in Canada, in Ontario? So this is a doc that I met through the Cascades program because I did some of the programs with them. And this person thought, hey, this is fantastic. So what I'm going to do with my residents, with my young, impressionable residents, I'm going to create a competition to see which ones could change the most people from an MDI to dry powder. Okay, I'm sure they're all going to be wonderful doctors. Right now, they're junior. What do? They change. You think they taught them? No. Right? I spent an hour and a half on the phone with this guy explaining to him why this maybe isn't the best idea in the world. And to give him credit, he appreciated that this was wrong. He had to make a change. Except the competition's still going. A few years ago, I got commissioned to write this article about what to do when you're switching inhalers. So with Job Van Voven, a friend of mine from the Netherlands, so we created this article. It took me a while to write this article, to get all the evidence. We came up with a mnemonic. Changing inhaler should be on your radar. U for uncontrolled disease, R for review the patient to see why, A for assess the patient's skills related to inhaler, D for discuss inhaler switch options, A for allowing the patient's input, and R to re-educate, and then of course follow up to get back to it. It's an open access paper. Look at it if you want. So that's a lot of steps. That's a lot of steps. And that's the point. If you're going to change inhalers, you have to go through those steps. This is just a poster at the ERS. Basically, what they said based on this group was it takes 35 minutes per patient to change inhaler. What's the average time a physician spends with a patient? Yeah. It's about 8 probably. It's not even as good as 10, frankly, but okay, right? So 35 divided by 8, that doesn't work to me somehow. That math doesn't work, but maybe someone can help me with that. All right, Can all of our patients use a dry powder? The very young, the very old, an emergency, peak inspiratory flow? So the answer is some, but not all. And it's not always so easy to recognize who they are. So this, again, looking this stuff up was very interesting for me because I said, okay, what about preschool kids using dry powders? We all know that's a bit of an issue. Okay? As you get older, you get better and better at it, but you can see when you're very young, it's as low as 30% could do it. These were healthy kids. These were not kids with disease, and they all were coached, and it was all tested using this in-check device. Anybody using an in-check device? Okay, a few of you, right? So that actually allows you to actually measure the inspiratory flow based on the device that you're actually prescribing. So it's very reliable to let you know if you have optimal peak inspiratory flow or not. So what that means is to get a dry powder, dry powders work, right? You have to suck in on them real hard, right? Why are you sucking in them real hard? Because you have to get the powders to go through whatever system of whichever drug it is, device it is, to break down those bigger particles into smaller ones so they can get small enough to get into the lungs. If you can't suck hard enough, it'll break down. So you get big particles that get all stuck in the upper airway and probably don't go anywhere, right? Remember in COPD, you're hyperinflated. So if you're already starting off really, really full, you have nowhere to suck anything else. So if you have suboptimal peak inspiratory flow, that's an issue. So kids may well not have sufficient inspiratory flow. And children and adolescents do worse than asthmatics in terms of having peak inspiratory flow. It's another article that showed this. So it's potentially an issue. Okay? If you have an in-check device, which some of you do, it's great. You can just test it. Most people don't have those things, and it's trouble to wash them between patients and so on. So it's a difficulty thing. This work looked at people with suboptimal peak inspiratory flow, okay, in stable versus exacerbating COPD. So green are the ones that can and will do. The blue are the can but will not do. That just means they're difficult. I don't know what that means, but okay. And the reddish one means they just can't do it. You had patients like this? Anybody? I remember the first person that came up, and I got a call from a pharmacy saying, and this was the January device. Remember the one that was green and turned red and turned back green, whatever. It popped up, and he said he can't do it. I thought, come on, of course he can do it. No, he said he can't do it. I said, okay, well, send him back to the office. In the office, I spent a half an hour with this guy. I know I said 8 minutes, but really I spent a half an hour with him. And he couldn't do it because he was so hyperinflated, he just could not do it. So it taught me, by the way, a January device is a really nice test for suboptimal peak inspiratory flow. If they can't make the thing pop up, they don't have enough. Just a little tip. It's cheaper, just get an old, except you can't get this stuff so many, but get an old device and use it that way. So what you can see here, first of all, is a certain percent of people have suboptimal peak inspiratory flow in COPD, but especially after exacerbation. So after exacerbation, when you're sick, you're sicker, you're a little more hyperinflated, and you're even sick, your muscles are maybe not as strong. You have some steroids, which affects your muscle. It just goes on and on. Okay, so it's maybe not surprising that the highest risk of exacerbations is right after the last one because they can't get their medicine in after exacerbation. So I actually created this tool years ago when we put it into the article, right? Who should you suspect suboptimal peak inspiratory flow? Well, if you think about it, it's a good idea. Their symptoms are refractory to therapy. It may not be it's the wrong therapy or the wrong diet. It may just be because they can't get the medicine in. A little higher in women than men, a little higher when you get older, that makes sense. And the more severe your disease, the more likely you are to have a problem. So you're considering this as one of your decisions as you choose between an MDI and a dry powder. Well, but wait a minute, we're getting rid of MDIs, so we're just going to use dry powders, all right? That was a little bit sarcastic, okay. Can you give beta agonists during an acute asthma exacerbation as a dry powder versus an MDI? The older data, and these are both old studies, say you can, right? Okay. I don't feel quite as good about it. When someone is really in trouble with significant asthma exacerbation, if it's a mild one, it's just, there's just not too bad symptoms, it's probably okay. But anyhow, there's evidence here that says dry powders are going to be acceptable to use for acute asthma exacerbation. Okay, some of you have experienced a little different than that, but that's what the evidence that I could find on this. There wasn't a lot, it was all old studies that showed this. This is an interesting article to me. So just talk to, what about the other way? How about people you switch from dry powders to an MDI? Okay, this is a study in Korea, and it was a bit of a database trial, so it's not really exactly what I'd like to do, but it looked at people, if they switched from the dry powder to MDI, did they have better persistence in their disease, and did they have better control? And in fact, if they switched from a dry powder to MDI, they actually had better control, and they had better persistence, probably because they felt better, so they kept taking their medicine. So again, a lot of people can take dry powders perfectly well. I prescribe a ton of dry powders, and you guys all use a ton of dry powders as well, but there are some that don't do very well, and our job is try to figure out who they are. So this whole climate thing, so the Family Physician Areas Group of Canada, which is the group that I chair, it's a group of respiratory, initially physicians, I'm going to come back to that, with an interest in respiratory medicine. We decided we needed to create some kind of statement on this. Okay, so quickly I'll go through it. You don't have to read the whole thing. It's on the website if you really want to look at it. Greenhouse gases are a concern. The enthusiasm to switch and reduce PMDIs is laudable, but okay, most MDI use is in short-acting beta agonists, which we should be minimizing anyhow. Make the diagnosis. Okay, get control. If we get rid of all MDIs, there's going to be consequences. So this is all sounding familiar, is what I've been talking about for the last few minutes. Right? That research on lower emission PMDIs is ongoing. Okay, and maybe not throw the baby out with the bathwater. Once we get new ones, if the patient prefers an MDI, we've got something coming. Okay? Unilateral changes by either the physician or the pharmacist or even the educator shouldn't be done. This has to be done in conjunction with the patient. We have to make sure that the whole team is working on the same thing. And again, disposal. So MDIs, once empty, need to be disposed of properly. We need to create a routine program in Canada where all MDIs, no matter what type, are returned to a central area. The only place I can think this is ever going to work is going to be the pharmacy. Okay, and I'll talk a little bit more about that. So we can change devices. I've talked about soft mist. We talked about dry powder. Make sure that the inhaler can be used properly. And during a more acute asthma or COPD flare-up, dry powders may not be enough. Back to disposal, which we'll talk about. Okay. Big picture, we can make a difference for both our patients and the planet at the same time if we do the right thing for the right person. So let's talk about disposal. What do your patients do with their drugs when they're finished with them? They throw them in the garbage, right? Is it okay to throw MDIs in the garbage? Is it okay to throw hairspray in the garbage? No, right? Because you know what's the risk. It can theoretically explode. Has anybody actually heard that happening? I keep hearing about it. Anybody? Yeah? Okay. You want to tell the story or no? Yeah? You can take your time. I'm okay. I'm here all night. Wow. So glasses are very protective. I can't tell you how many times I've done that with a barbecue, but that's a whole other story. But the point here is we don't want to be doing this accidentally. We don't want to hurt people that we're working with because they can explode in a garbage truck. They can get crushed, right? They often crush them, things like that. They also release greenhouse gases. What a surprise, because they're often not empty when they're thrown out, or they still have propellant in them when they're thrown out. So when you crush them, it releases the gas. Aren't we trying to prevent the release of the gas? Isn't that what we're trying to do? And of course, they can also leak into the landfill if they get thrown out into a landfill. So if patients don't know when they're empty, or there's still propellant left and we do that, how are we going to actually deal with these, right? So hopefully we can get them taken back to a central place and then dealt with. I'll talk about how they get dealt with. Because if you just throw them in the garbage or you just crush them, then we're going to actually release those gases. So we need an infrastructure in this country. Okay? So we had this conversation at the RTSO meeting recently, and Andrea challenged us to have that conversation here as well. So I'm now reaching out to different organizations to say, how are we going to all advocate together? It's just my little airway group isn't going to do it by itself. But if we all do it, the entire respiratory community says, hey, wait a minute, this is a problem. Okay, and we need to fix this. But there's going to be a cost component because if pharmacists are going to do it, they're going to have to figure out a way to deal with them. They're going to have to be disposed. So this is something, again, I want to save the planet. I want to save the climate. Who am I talking about, right? And if he's actually going to do something that's going to be useful, well, let's find something like this, which is useful that we can advocate and put some money into. So there's an entire science to this, by the way. This is not just me making this stuff up. There's an entire science to this. There's actually American Chemistry Council talks about disposal of MDIs and so on. Right? So we can recycle them. We can incinerate them. So incinerate them actually burns up the gases entirely, so they're not getting up into the atmosphere as well, both of which are going to make a difference in terms of release of greenhouse gases. Okay. So this abstract, I think at a British conference, talked about if 30% of patients change their behavior and dispose of the local pharmacy, which they do in the UK, would save 11 tons of carbon emission. Use 4 inhalers a year. That math is really hard. You get to 44 tons, which is a lot apparently. I can't lift that much. I don't know what that means. Okay. Secondary care clinic in England. They actually looked at this. Okay. All these patients were supposed to be recycling inhalers. They're all educated, but only a third of them did. Okay. Okay. And despite they're educated, half of them had no idea what they were talking about when they were told about it. Okay. And they just throw them in the curbside recycling bin. Okay. So that's good. We all have our blue bins, right? It's blue across the country. We all have blue bins for recycle. Okay. So it gets thrown in there, but then what happens to them? Half the time it just gets thrown in the landfill anyhow, right? You know that. Right? So this was in India and goes back a number of years ago, but they said the same thing. They need to in India said this, they need a take-back program to recycle or incinerate them to make it safe. But they're burning coal. So this is some of the little signs that are up in some of the UK pharmacies. So this is the thing that's happening in the UK, not happening efficiently or effectively right now, but it's certainly something we can build on. You get the idea of certain different signs that have been put up for disposal and that idea. So big picture here in the Lancet, this conversation talking about some of the people from the GINA group said, well, let's make sure that we have supplies of curb propellants until inhaled medications with low global warming potential becomes available. That's a pretty reasonable thing to say. It took 20 years for CFCs, but we're going to do it in 3 for HFAs. Now that's kind of hard for anyone to actually make that happen, right? We have to have enough time to create the new inhaler devices to allow something to replace it, because there are groups that are going to require MDIs. So can we decrease the amount of MDI without endangering our patients? I think the answer is yes. How do we do that? Well, get control, improve technique. Right? We all know the technique is not there, and guess what? If you're spraying out here, it's probably not going to work for your lungs. You're going to take more in here and more here. It's maybe eventually get some in your mouth, right? That's what's happening out there. You know that. Let's make sure it's not being wasted, and a spacer might help, right? Now, this is an old COPD trial, and I pulled it up just to show. First of all, you know that you see the percent of healthcare practitioners with correct was under 25%. Right? So that's pretty sad, right? And in the first period to the second period, if you look at the 20-year intervals, it actually got worse. So not only are we not getting better with inhaling technique, we're actually getting worse, except the group that used the inhalation chamber. Okay? So if you use chambers, actually that got better. So there's hope. Okay? You know all the signs that MDIs, get the medication down into your lungs so they work better instead of just all being in the throat. And there are these new climate-friendly propellants coming, as we talked about. Right? So here's sort of what they are in terms of the slight differences. So the HFAs are the ones that are currently available. The HFC is the one sort of closest to being available. And the HFO, which you can see is even better in terms of those levels, again, is a little further apart. So all of this, hopefully will be available by 2025. They're available now, but then you have to start getting the medications into it and getting the testing done, and all it takes time. The other issue that you may or may not have heard about is called PFAS, or per and polyfluoroalkyl substances. You have to say that 3 times fast. Okay? Now, what happened with this is these are nasty, nasty things, and they can sit in the environment forever, like they never get broken down. And they lead to bad things, they lead to cancers, lead to all kinds of really awful reproductive effects. They're bad things. And the problem is this European group, which recognized this, which is really important. Okay? They said, we have to ban all these. But how did they define what they were? They defined them based on the chemical structures. Anything that looked a little bit like it was included. 10,000 chemicals were all the same. So this HFO one that I showed you, that looks like a PFAS. So therefore, it was included. So a bunch of us have then written letters to this European community. I don't know if they care about getting a letter from a Canadian primary care group, but they did, saying, hey, okay, just because it looks like doesn't mean it's the same. In fact, it's been studied and shows it doesn't cause all those things. It does get broken down. It doesn't sit there forever. So this is another area. So when we look at these again, these new ones that are coming, and the F-gas legislation is being affected for the HFC 152A, and the PFAS is going to be for the HFO. So while we have some new ones that are in development, we may not have any of them available to us because all this legislation is going to say you can't use them. So our greenhouse gas is the only thing that happens when we inhale something or when we use an inhaler. Where else do these pieces of plastic and little pieces of metal and things, where do they end up? Yeah, in the ocean, I'm hearing, which is great, right? So this gives you an idea. And again, lots of different things. Global warming potential is on the far left for you. You get an idea of marine ecotoxicity and so on in there. So that's the HFA currently. This is the HFA 227, and this is dry powder. Right? So this plastic we have to deal with as well. So it's not just what's in the air. We have to get rid of all this stuff. It's amazing that in Europe, you're all familiar with the Respimat device, that soft mist inhaler, right? They have a plastic piece, and you can use three different canisters. So you can reuse the piece of plastic. Okay? Well, not in Canada, because they're not going to put the work into it here, because the government gave them too hard of a time. It wasn't worth it for them to spend the money to do it. Not fast-tracking intelligent prevention of climate issues, another example of that, right? So that's the differences there. Right, so everything we use has a cost. It's not just about the propellants that are in the MDIs. Right, so overall, our key messages are environmental issues are really important. Changing to environmentally friendly inhalers is certainly one part of the equation, but not all of it. Okay? We have to make sure our patients are being prioritized first. Switching is fine if you do it right? And let's make sure we prevent attacks, because every attack we have, especially hospitalization, leads to increase that as well. ERS said the same thing. As clinicians, our duty of care is to the patient first. Patient safety, efficacy, and choice must be the primary drivers. So we don't do things just because. Some of you may have seen the recent CTS position statement on climate. Just a quick summary of that. Okay? So patient preference, adherence issues, inhalation technique, inspiratory flow, patient age, cost, side effect. And then, after all those things, environmental footprint. The message is recurrent. I'm sorry for repeating myself, but the points here are being advocated by so many different groups and so many different people. We have to be careful what we say. Again, another way of looking at the goal, I'm going to skip this just for time. One other thing. Some of you may have seen this idea, the concept then, well, I've talked about it a little bit already. The inhaler you're using, that posted inhaler you're using is causing effect on the climate. So we call this green guilt. And this is mentioned in the GINA. Potential of placing an additional burden on the patient because of green guilt. So you're using an inhaler that's bad for the environment. Shame on you. This is your fault. Nothing to do with the coal plants. No, but this is your fault for using an MDI. Okay? And this is going to affect adherence. What's that going to lead to? Exacerbations and even worse things to the environment. Asthma is not a lifestyle choice. You don't get this because you did something wrong. It's a disease you have. Okay? We should not be shaming people for the inhaler they use, but that's one of the techniques that's being used out there to try to get people to change. So I'll summarize. Greenhouse gas emissions in medicines comes from multiple sources, and we need to do about what we can do. Okay? They're mostly correlated to disease not being well controlled because of exacerbations leading to an increased footprint. They're mostly controlled to SABA use, which is far and away the most PMDIs being used. Right? So get control, decrease healthcare utilization, decrease the number of puffers being used. So how do we do that? We have lots of unmet needs, and that's what we spend all of our days doing as educators and clinicians. Okay? Let's make sure that at a population level we can reduce carbon input from lots of different ways. DPIs are certainly a really good answer for the people that can use it. Okay? Let's try to get new propellants that will be acceptable and useful. And that disposal thing, I still haven't figured exactly how we're going to do this, but I think we need to work together to advocate for this. So we can all do a little something. And by no means am I saying that we should not do everything we can do to do it, but we shouldn't do it at the expense of harm. That's really my message at the end of the day. If you can make a change to something else, make the change. Make sure that patient knows how to use their device. Make sure they're doing well with it. Okay? As clinicians, that's the prototype family doctor, right? Marcus Welby. Right? Some of you are too young to know who Marcus Welby is. That's when I get really scared, but okay. For me, not for you. All right. Whether you're educators, where are you in the world, I think the point is do the right thing. So my email address is there, but also the Family Physician Airways Group of Canada website is there. We have made a decision last year at AGM that we think that we should no longer be the Family Physician Airways Group of Canada, but it's too hard to change the name because of all the rules. But we want to invite all primary care practitioners in respiratory disease to join us. So feel free to do so. We have lots of tools on there you might find useful. I know some of you use our spirometry algorithm, for instance, because I've been told that. Lots of tools there. So please feel free to join up. It doesn't cost anything. You'll get an occasional survey, perhaps, something like that, but nothing that's going to be very much. So please feel free to join up if you have any interest at all to do that. So I'll stop there for time because I've probably gone over, which is usually what I'm guilty of. Cheryl hasn't thrown anything at me yet, so I guess I must be doing okay. And happy to answer any questions. So thanks very much.
Thank you, Dr. Kapling, for this wonderful talk. I wonder also, could it be possible the way you prescribe Ventolin versus saying 12 inhalers, could we maybe prescribe it in a way that we're not, I'm not saying allowing the client, but maybe limiting the amount that we're giving?
So the question was, how we actually prescribe and make a difference? And of course, the answer is yes. I don't use a lot of PMDI Ventolin anymore altogether. There's lots of other alternatives for that and lots of different strategies. As you all know, I'm trying to stay away from any drugs, but that's there. You're all familiar with that. Yes, I think that we should just give one inhaler, maybe a second, right? And no repeats. So unfortunately, the most common prescription is 2 puffs QID PRN, 3 inhalers, 3 repeats. And that's just a lot of inhalers, right? And and you have no idea how many they've used. There's no feedback. Again, I apologize to any pharmacist. I've only been doing this for 40 years. I've never had a pharmacist reach out to me and say, your patient just had their 10th Ventolin. Never. Every other story in the world, yes, I've had, but that one I've never had, right? So why? Why are we not working together to look at things like that? But I don't give repeats. If you need another one, you should be talking to me, right? And that's the thing we should do, right? We need to evaluate why people are needing, right? Right? You know what the control things, right? Right? Twice a week, right? So 2 puffs, twice a week. More than that, you're not controlled, whatever that means, right? That's 4 puffs a week, 52 weeks. Okay? That's 208 puffs, right? How many puffs in one inhaler? 200. So one inhaler should be plenty. Okay, fine, 2. Yeah, I know sometimes they put in the gym bag and sometimes in the car and sometimes in the cottage. I get all that stories. I don't believe any of them, but fine, all right? But we know all that stuff, but we need to limit. So it's a really easy technique to say, and if you need another one, okay, then I'll give you one, but we have to follow up with the why did you need that one? Because that's, it's going to be inhaling, it's going to be technique, adherence, all the list of things that we all know to talk about. So yes, it's a simple thing to make a difference. I agree. And I say this every talk I give family docs, and have the same thing. Stop giving Ventolin repeats. Why? It's too much trouble, right? Yeah. And unfortunately, they are busy. And they're overwhelmed, and that's an issue. I was mentioning earlier. I saw the picture say we need a note for air conditioners and air purifiers in BC. Great, another note I have to write. Looking forward to that one coming to Ontario. Anyhow, off topic. Andrea.
Thanks for coming, Ellen. I know you're busy. I'm just thinking about. I have very little time left, and there's a lot to do. And I know that I think that this, how we dispose of inhalers is important. I just want to clarify in my own mind, are you talking about just PMDIs or are we talking about all inhalers?
So I think it should be all inhalers, but there's different issues there. So, I mean, frankly, if we use an MDI and we take the canister out and put the plastic somewhere else, we could recycle the plastic and deal with the canisters. And that's one thing. A lot of the dry powders, though, have more than just plastic in them. Little tiny pieces of metal in them and stuff like that as well, which can actually make it difficult to recycle them. But in an ideal world, we'd be in a situation where we could recycle all the dry powders as well. It's going to be a little more technically difficult because of the other components that are in there. So yes, it would be the answer to start with. But I also have to reasonably say, is the technology actually there to do it? So that's going to be a little tougher to arrange. But yes, in a perfect world, and maybe in a not so perfect world, that's where we should be going. Well, this shouldn't end up in the ocean, right? We shouldn't be having plastic in the ocean. I mean, it's insane. If you've seen the pictures of the bottom of the ocean where there's plastic and bottles and plastic bags, So now we can't have plastic bags, we can't have plastic straws. Okay, fine, but it has to be, it has to be dealt with properly. And disposing of it properly, like recycling, would make sense, Andrea.
Yeah, thanks.
I'm gonna jump in here.
Yeah,
That was
shut
pretty
me
good.
up.
That was pretty good. You're only a little over.
Okay, that's good for me.
But we planned for that. We planned for that.
That's why you put me at the end. So,
Yeah.
yeah.
But,
You got really
but-
upset, you just all walk out.
But
That's
you
fine.
see, no, everybody's still here, and I have to thank Dr. Kaplan so much. Always one of our most popular speakers, and how committed he is to our organization. He flew in this morning, and he's going to get a red eye to go home because he had another commitment tomorrow, and still really wanted to be here to talk to us. So let's really show him some love.
Hey, I'm going to thank you and Cheryl. I'm going to thank you because it's always a pleasure to come here. It's always a pleasure to see some old friends and make some new ones. You guys are a really important part of how we manage asthma and COPD and other things as well in Canada. And again, as Cheryl said, I've been an advocate for a long time because I think we need to do team medicine in order for anything to work in this country. And
Yeah.
you're part of that team. So
Yes.
Yeah.
yes,
Okay.
yes.
Thank you. So that wraps up our program for this evening. We begin tomorrow again at 8:00 a.m. Breakfast will be served at starting at 7:30 in the exhibit hall. And everyone enjoy the rest of your night. Some of you are probably a little jet lagged. So thank you, and we'll see you tomorrow. And thank you, Dr. Kaplan.